Hello, everyone. Welcome to our Monday morning webinar. I am Srikriti Baskoda, presenter of today's webinar. I am graced by Dr. Okoye. She's here from Houston Methodist, and Dr. Lin, she's also representing Houston Methodist, and we are also graced by our eJournal committee chair, Dr. Rezai. She's coming from Quest Diagnostics from Virginia. Welcome, everyone. Let's get started. We also had a very exciting chat event last night. Thank you, Dr. Okoye and Dr. Crumley, for being there yesterday night. You can also go back and see our exciting discussion. The polling are still open. You can give your opinion. So the topic of today's discussion is the false negative Papanicolaou test in women with biopsy-proven invasive endocervical adenocarcinoma, AIS, a retrospective analysis with assessment of Interobserver agreement. It was a study done in 3 institutions, Houston Methodist, MD Anderson, and 1 laboratory in Thailand, and it was published in JAS in volume 11 of this year. And I am, as I said, I'm a secretary. I am currently at Columbia as an assistant professor, and that is my Twitter handle, Baskoda. Dr. Okoye is an assistant professor at Houston Methodist, and Dr. Lin was a prior Breston GYN fellow and current PGI-4 resident at Houston Methodist. Before we move on, I have a question for Dr. Okoye and Dr. Lin. How did you came across this idea of doing this project and collaborating with a lab in Thailand to this project?
Yeah, so we actually had, thank you so much for the invitation, first of all. We actually had visiting a fellow with us from that institution. We have a partnership with that institution. Dr. Modi, who I'm sure many of you are familiar with, has lectured there many times. So she developed a connection there. We had some of their trainees come over to our institution. So that's how that happened.
Wow, that's great. Dr. Lin, you must be really fortunate to be trained under so many great people. What was your experience in this project?
Yes, and again, thank you so much for having me here today. Yes, it's definitely a great privilege to be able to train with Dr. Okoye and Dr. Modi and all of the great faculty that we have here, particularly in cytopathology. We actually collaborated with, we actually have a contract with the bioreference laboratories here. They work in Houston and in New Jersey. So that's one of the ways that we were able to amass so many samples to analyze for our project.
Great. Okay, let's get started. So the objectives of today's eJournal presentation is to discuss about the incidence and factors which leads to a false negative endocervical adenocarcinoma and adenocarcinoma in situ in cytology, and to talk about 3 different factors of the false negative endocervical adenocarcinoma and adenocarcinoma in situ, which are sampling variants, screening variants, and interpretive diagnostic variants, and role of educational instruction in reduction of interpretive variants. So in talking about introductions, incidence of invasive endocervical adenocarcinoma has increased in recent decades to up to 20 to 25% of all cervical carcinomas. The reason behind this is the widespread use of screening Pap test for the detection. However, Pap test is not as successful for the detection of precursor glandular lesion at the same level as of precursor squamous intraepithelial lesion. There are many contributory factors for a not successful screening Pap test, which include sampling issues, very subtle cytology criteria as defined by the Bethesda system, and the low level of concordance in the diagnosis of glandular lesion. The range of sensitivity also varies for the detection of endocervical adenocarcinoma and the adenocarcinoma in situ, which ranges from 45 to 76% in the initial studies to a more recent studies, reporting high sensitivity rates of 88 to 92%. So factors leading to the false negative endocervical adenocarcinoma, or AIS, can be broadly classified into three categories, which are sampling variants, which is defined as neoplastic cells are not present in the cytology preparation, or screening variants, in which neoplastic cells are not recognized using either automated or manual screening by the cytotechnologist, and diagnostic or interpretive variants, in which neoplastic cells are misclassified by the cytopathologist. Furthermore, talking about the causes of the interpretive variants, there are many documented causes in the diagnosis of glandular neoplasia, in which the glandular neoplasia have been mistaken for abnormal cells as reactive endocervical cells or endometrial cells, directly sampled lower uterine segment, endometrium, tubal metaplasia, and atrophic vasinitis. Dr. Okay, I found this really challenging even in my daily practice, to diagnose abnormal glandular cells versus these close mimickers, and I believe you also come across the same challenging factors. How do you suggest us to mitigate these challenges?
Yeah, it is definitely a very challenging area because, like you mentioned, there are so many benign mimics. I think, for example, a menstrual endometrium or directly sampled LUS can be very challenging. So I think in that scenario, knowing the history is really important. For example, sometimes we don't always have the history, which is unfortunate. But if we do, know the history, if you know that the patient, if you look at the LMP, that can be really helpful if you know that the patient is menstruating. Just looking at other clinical clues can be helpful. The age of the patient can be helpful. Atrophy, you always want to kind of be more conservative when you're in the setting of atrophy. So just kind of looking at everything, looking at the clinical scenario can be really helpful, in addition to just using your criteria when you look at these cases.
Okay, thank you. Okay, let's move on. So discussing about the potential role of educational instruction in reducing the rate of interpretive variants, there has been very few studies published. Lee et al. Found significant increase in diagnostic accuracy of the small cell or endometriate pattern of adenocarcinoma in situ after targeted instruction on the specific criteria for this under-recognized variant. Similarly, Ruba et al. In their study found an overall decrease in the diagnostic errors in cases of AIS. So, objectives of this study was to identify factors contributing to false negative pap test in patients with biopsy-proven endocervical adenocarcinoma or adenocarcinoma in situ, and to assess the impact of educational instruction on the diagnostic accuracy and inter-observer agreement of these cases. So, talking about the material and methods and the consensus re-review of cases, it was a retrospective 3 years cases in which histologically proven endocervical adenocarcinoma and AIS were taken, and the parameters that were included were previous pap tests, high-risk HPV co-testing results, age, and the diagnostic intervals. All abnormal pap diagnoses, including squamous abnormalities, were considered positive results. And all negative pap tests within 36 months of biopsy diagnosis of endocervical adenocarcinoma or AIS were selected for inclusion. And these negative cases with equal number of controlled pap tests with a wide variety of diagnoses were reviewed by a majority of blinded group of 5 pathologists and 2 cytotechnologists at a multiple head microscope. Dr. Lin, can you describe a little bit more about this blinded group? What did you know about when you were participating in this study?
Yes, so this consensus group of pathologists and cytotechnologists, they were blinded to the original diagnosis. They were blinded to all clinical information, including the HPV status as well. So they just had these cases, which included the study cases of the false negative pap test, as well as a number of these control cases that were interspersed in, which had a wide variety of diagnoses, as you mentioned before, and they just had to go through and agree on a diagnosis for each case.
Perfect. Perfect.
One thing, can I add one other thing? Just like you said, they were also too blinded to the whole concept of the study, so they had no idea.
Yes, yes.
I see. That's really interesting and probably gives adds a lot more value to the paper. So, like Dr. Lin mentioned, the consensus group was blinded to everything, and the consensus diagnosis was rendered for each case with the diagnosis stratified into low risk and high risk. Low risk was a diagnosis of ASCAS and ALCIL, and high risk was a diagnosis of ASCAS, ALCIL, atypical glandular cells, NOS, favor neoplastic, atypical endocervical cells, and AIS categories. So for the analysis of false negative cases, again, the source of discrepancy for the false negative cases were categorized into one of the three: sampling variants, screening variants, and the integrative variants. So talking about the sampling variants, the number of endocervical cell groups were counted for the group were defined as 4 to 10 number of endocervical cells was calculated for each case, and the biopsy characteristics such as percentage of involvement by glandular neoplasia and involvement of the transformation zone were also recorded. For the screening variants, computer-assisted screening, negative diagnosis, or the original image or field of view were reviewed to document the presence or absence of the abnormal cells. For thin rib specimen, the hologic imager was used with 22 field of view assessed. And for shear-bath specimens, the BD focal point imager was used with 11 focal point of view assessed. And only for manual screening, 2 authors did the manual screening. I believe, Dr. Okoye, you were part of the manual screening process, right? Can you describe your experience a little bit to us?
Sure. So I will say that very few of our cases in our study only had manual screening, and that's because at our institution, pretty much all of our PAP tests utilize computer image screening. So the only cases that were manually screened, or maybe the slide was rejected by the computer imager or whatnot. So only 2 of our cases were only manually screened. The majority of them were utilized computer-based imaging, and that was performed by our lead technologist at the time, Ms. Angela Jones.
Perfect. That's really interesting that everything is automated at your institution. Okay. And talking about interpretive variants, the morphologic features of glandular neoplasia, example, presence of hyperchromatic crowded groups, frithering, were assessed for each case. Talking about in material and methods, the Interobserver agreement and the educational instruction, negative with the added control cases were evaluated individually in 2 rounds by the 12 blinded reviewers, which comprised of 6 cytopathologists and 6 cytotechnologists with experience of an average of 12.3 years. Between 2 rounds, an educational session on endocervical glandular neoplasia was presented by a gynecologic cytopathologist. Dr. Lee, can you tell us a little bit more about this educational session?
Yes, so this educational session consisted of first a PowerPoint presentation, which went over each of the Bethesda reporting categories for glandular abnormalities and cervical cytology, as well as the morphologic features of each category and ways to distinguish glandular abnormalities from benign mimics. And then the second part of this session was a slide session where slides of various glandular abnormalities were shown during the session.
Perfect. I'm sure that educational session was a great refresher for everyone.
Yes, definitely.
Yeah. So to eliminate the reviewer bias, which I'm going to talk about in the limitation as well, a washout period was implemented of 2 to 6 months between the educational session and the second round of the individual review. So let's talk about the results. The total number of the cases included with biopsy-proven endocervical adenocarcinoma and AIS was 79, out of which there was a false negative PAP in 22 of the cases and epithelial cell abnormality in 57. All the negative PAP had positive high-risk HPV positive, all with positive 68 in 22 out of 22 cases, and at least 38 of them had positive 1680 in the epithelial cell abnormality groups. And the low risk and the high risk we will talk about in the next slide as well. So this shows the cytologically negative cases, 22 cases, and the cytologically abnormal cases. Talking about the cytologically negative PAP 22 cases, the interpretive variance accounted for 10 cases, screening variance accounted for 2 cases, and the sampling variance accounted for 10 cases. And these are the clinical pathology characteristics among for the false negative PAP and the abnormal PAP groups. Average age, high-risk HPV positivity, in situ versus invasive disease in the follow-up biopsy, associated squamous intraepithelial lesion, and interval from PAP to biopsy in both the groups were almost similar, and none of them were statistically significant. Talking about the negative PAP or the false negative PAP group, 10 were negative and 3 were reclassified into low risk category and 9 were classified into high risk categories. Among the 9 classified into high risk category, 1 was categorized into HCL, 3 was categorized into AGC-NOS, 1 was categorized into favor neoplastic, 2 into atypical endocervical cells, and 2 into AIS. So these are the different error type which are among those 22 cases, and all those the 10 cases which were negative in this figure are due to sampling error. That means we did not find any atypical cells. So that implies there was no atypical cells in the cytology preparation, which is sampling error. The 2 cells, the 2 of the samples was due to screening error, where the atypical cells were missed by the manual or the automated screening process, and the rest were by the interpretive error. So this is one of the example in which the case was reclassified as AIS, in which the false negative diagnosis was attributed to the interpretive variance. You can see there were numerous groups of endocervical cells with a hyperchromatic, crowded, and even the feathering was present. And inter-observer agreement was high among the individual reviewers in both rounds of review. So this is another table in which it's shown whether it was kept as negative or upgraded to low grade or high grade. As you can see, there were many in which the SEER path was kept in low grade. However, in thin prep, there was many upgraded. So do you have any experience like this in your institution or before as well, Dr. Okoye?
Yeah, so this difference was pretty striking. Just kind of in day-to-day practice, I had not noticed that the difference before. So one thing we wanted to do when we saw this was to see, well, is it because in this particular cases was the SurePath sampling the endocervical canal better? Did we have more endocervical cell groups in the SurePath PAP test versus a thin prep? And there really was no difference in terms of the endocervical cell group. So.
Yes.
I'm not really sure exactly as to why there is this distinction. You know, there have been some studies showing, some authors initially have stated that glandular detection is easier in SurePath, but then there have also been studies showing the reverse in thin prep. So the studies are kind of mixed. I think it will be actually interesting to study this further and to actually see if this actually holds when we look at a larger number of cases.
Right, yeah, that would be an interesting study to do in future. I totally agree. I didn't realize there would be difference in the preparation.
So one thing we do know though that there are some cytologic change, some differences in terms of the appearance of glandular lesions in SurePath versus thin prep. So SurePath has more single cells or more strips of cells, but it was pretty interesting finding.
Right. Another interesting finding in this table is like the average number of endocervical cells found in PAP was low when the PAP was kept at negative versus it was really high when it was upgraded to a high grade lesion. As you can see, 3 versus 15.1. So this is another image in which the case was reclassified as AIS with a false negative diagnosis, again attributed to interpretive variance. In A, you can see a scattered hyperchromatic group with an increased NC ratio, but it also has inflammation in the background. There was but here you can see there is inflammation, but it has high NC ratio, hyperchromasia, very hyperchromatic group. But if you compare these, this looks a little bit hyperchromatic, and this is much more hyperchromatic. The inter-observer agreement in this particular case was low in the first round of the individual review, but there was a modest improvement after the education and a washout period in the second round. So this is another table in which they listed different findings, a morphologic analysis for the cases upgraded to the glandular abnormality in a consensus repeat review. The different morphologic analysis they assessed was the abnormal cell score, hyperchromatic crowded group, nuclear enlargement, nuclear overlap, feathering, pseudostratified strips, rosetting, and the obscuring factors. Can you tell us a little bit more about abnormal cell score, Dr. Lin?
Yes. Sure. So this, sorry, do you want to go ahead? Go ahead. Okay, so this is kind of just a semi-quantitative score that we used to categorize all the cases. So I think if you see in the last line of the table, 1 corresponds to few cells, 2 corresponds to moderate amount of cells, and 3 corresponds to many cells.
Right. So as you can see in this table, there were many cases in the atypical glandular cells category where they found hyperchromatic crowded groups, but more typical features of AIS are atypical endocervical cells like feathering, pseudostratified strips, or rosettes were not common in this study. And there were also obscuring factors like straining artifact of atypical inflammation, which must have been challenging in the part of their study as well. So this is another figure in which it was classified as atypical glandular cells favor neoplastic and with a false negative diagnosis, again attributed to interpretive variance. These glandular cells has a slightly rounder nuclei and was interpreted as endometrial cells, but with the nuclear enlargement and continued irregularities, they are more compatible with neoplastic process. The inter-observer agreement was low in the first round of the individual review, with very minimal improvement even in the second round after the education and the washout period. So this is again a table of the analysis of the individual review response and the interpretive variance false negative PAP upgraded to a glandular abnormality and a consensus repeat. And here you can see how they did after the corrective round 1 and the corrective round 2 for the interpretive and the screening error type, and what was the diagnosis in the first diagnosis of whether it was a reactive glandular cells versus endometrial cells, and this was only in the round 1. And this case was reclassified as atypical glandular cells NOS and a false negative diagnosis attributed to a screening variance. As you can see, there is an abundant inflammation present in this case, and there was only one diagnostic glandular cell group with hyperchromatic and enlarged nuclei. And the inter-observer agreement was very low in both round of the individual review, which shows a significant challenge in arriving as a consensus diagnosis in cases like this, with a very scant abnormal cells and superimposed by obscuring acute inflammation. And this is a table which shows the agreement as assessed by Cohen-Kappa statistic between individual reviewer diagnosis and consensus diagnosis. As you can see, both whether the reviewer was a cytotech or a cytopathologist in the round 1 and round 2, at least we saw like fair to moderate agreement increase in between the round 1 to round 2 after the education and a washout period. So talking about the discussion, let's talk about the importance of co-testing. In this study, the overall sensitivity of the Pap test for the detection of endocervical adenocarcinoma or AIS after review of all false negative cases was 87.3, which is comparable to the sensitivity rate in all other recent studies. The overall high-risk HPV rate is 93.8%, which is in the line with those obtained in previous studies of glandular lesion in Pap test. However, 4 cases included in this study were high-risk HPV negative, and these would have been missed if HPV-only screening had been performed. It supports the use of co-testing with both cytology and high-risk to optimize the detection of glandular lesions. So Dr. Ikinoi, sorry, Dr. Okoye, do you still perform co-testing at your institution, or have you adopted primary screening?
So we have, very few of our clinicians do primary screening.
Right.
So most still are doing co-testing. Some are still only doing cytology, unfortunately, but most of the cases we receive are co-testing or reflex high-risk HPV testing.
How about your institution, Dr. Rezai? Are they planning to adopt any change?
Well, my institution receives specimens from all over the country, so there are many different practice types. We do have some, as Dr. Okoye said, there are some, but not the majority of cases that are for primary screening, but for the most part, we get the co-testing and some as a reflex only. But overall, I think we still are outweighing the primary screening, and I think there is a lot more data hopefully to support that, at least in the coming years.
I really hope we have more data coming. Oh, okay, let's continue. Thank you. So let's continuing discussion. The presence of squamous dysplasia. Out of the 35 or 57 of abnormal Paps, or the 61.4%, had a diagnosis of squamous cell abnormality in the study. 2 additional cases had concurrent squamous and glandular abnormalities. And prior studies have suggested that the presence of squamous dysplasia and Pap test increases the sensitivity for the detection of glandular neoplasia. However, this study showed no association of squamous dysplasia with increased detection of glandular abnormalities. Talking about sampling variance, 10 out of 22 false negative Paps had sampling variance for false negative attributes. They significantly had fewer endocervical cell groups compared with other false negative Pap tests supporting sampling variance. Sampling devices for Pap tests have significantly improved, but however, it is still challenging to sample for glandular lesions because they often occur higher and deep in the endocervical canal. Most false negative Pap with the sampling variance in this study had endocervical adenocarcinoma or AIS not involving in the transformation zone. Example, they were only present in the endocervical curettage on subsequent biopsy, but findings were also seen in the biopsy from patient with false negative Pap test not attributed to the false sampling variance. All false negative Pap tests with sampling variance were HPV 16/18 positive, which is a very interesting finding. Hence, we can conclude that high-risk HPV results is instrumental in directing appropriate follow-up and glandular abnormality in the cases where glandular abnormalities were not sampled cytologically. However, interestingly, management for these cases would not change the recent 2019 ASCCP risk-based management guidelines. They would still do colposcopy with a negative Pap finding if the high-risk HPV is positive for 16/18. So talking about the screening variants, 2 of the false negative Pap tests were attributed to screening variants in this study. Both cases had very rare abnormal cells, and 1 also had abundant obscuring acute inflammation. In both, abnormal cells were not identified by computer-assisted automated and they had to do a second manual screening, underscoring the difficulty in preventing screening variants. And the cases also had very scant diagnostic abnormal cells. So in overall, computer-assisted automated screening is an effective mechanism in identifying glandular lesions. However, it poses a small risk of missing significant lesions, especially in those with only few diagnostic abnormal cells. Dr. Okoye, what is your thought regarding this? Do you think that we should subject these cases with a history of prior abnormal glandular lesions to be subjected to automatic manual review to, minimize this risk of uh, detecting abnormal glandular cells in cytology?
I'm so sorry, I didn't hear the first part of the question. Can you repeat it again?
So if, since we found 2 cases which were missed by automated screening process, do you think a cytologist here with a prior history of atypical glandular cells in cytology should also be reviewed manually by your experience so that we...
Yeah, I mean, it's definitely something to consider. However, in this case, even on manual screening, they were still missed. And also, I don't want to overblow the risk of missing on the screening. I mean, I think, as it shows, you can miss on manual or computer assisted. So I think it's something. One thing I will say that I'm not sure I think you're going to get to is just focused rescreening. So one thing that we do at our institution is when we have co-tests of NILM and a high-risk HPV, before we send that out, we have another screen. We have another screen be done before we send out a NILM, a PAP test, and a positive high-risk HPV. So those tests, we do have focused rescreening for those scenarios. So, but it is an interesting consideration.
Okay. So let's talk about interpretive variance. 10 out of 22 false negative PAP tests in this study were attributed to interpretive variance, and most had few abnormal glandular cells. While all cases were upgraded to glandular abnormalities, showed hyperchromatic crowded growths. More well-developed architectural features of AIS like pseudostratified streaks, rosettes, and feathering were seen in only a few of them. And on individual review, most frequent interpretive variance was underclassification of neoplastic glandular cells as reactive glandular cells or endometrial cells. And studies have shown that the small cell or the endometrial variant of the AIS as a source of interpretive variance in the PAP test of abnormal glandular abnormalities, but they did not find any of these variants in this study. So, interestingly, the interpretive variance was found more in the thin prep greater than seropath cases. 78.6% of the thin prep were upgraded versus 12.5% of the seropath, which was statistically significant. Studies have also shown that glandular abnormalities are more easily identified on seropath specimens, and hypothesized that different methods of preparation might yield to better yield in seropath specimens with more hyperchromatic crowded groups and better preservation of nuclear detail to facilitate diagnosis of glandular lesions. So, talking about consensus and inter-observer agreement, overall, the consensus was low in the first round before education, especially for the cases upgraded at the consensus conference. Of the cases upgraded to a high-risk category on the consensus review, only one case had good agreement in the first round. And this was the only case with abundant, well-preserved abnormal cells. In the second round, there was a significant improvement, which highlights the value of focused educational sessions, which is proven to increase the diagnostic accuracy. And the improvement was most dramatic for the cases which were upgraded to a glandular abnormality in the consensus conference. And cytotecs had a greater rate of agreement with the consensus diagnosis in the first round. 3 out of 6 cytotecs versus 1 out of 6 cytopathologists with at least moderate agreement. In the second round, cytopathologists had greater agreement than cytotecs, 4 out of 6 cytotecs versus 5 out of 6 cytopathologists with at least moderate agreement. Despite the significant increase in inter-observer agreement seen with education, agreement was still lacking for many cases in the post-educational round. So, talking about the challenges, 5 out of 9 cases upgraded to a high-risk category still had at least one half of the reviewers giving a negative or low-risk diagnosis in the second round. These included the 2 cases attributed to screening variants, which 67% and 92% of the individual reviewers still missed in round 2. The persistence of these interpretive variants highlights the exceptional difficulty in the evaluation of these false negative cases. So as I mentioned earlier, talking about the limitation, the reviewer bias, they were already primed to identify the abnormal glandular abnormalities. But as I understand, Dr. Okoye, we tried to eliminate the reviewer bias in the study by having the blinded group, right? Can you elaborate a little bit more about that?
Right. So we tried to minimize. So most of all of the reviewers were blinded to actually the whole concept of the study. They just knew that they were just meant to evaluate these pap tests, and the control cases as mixed in with our study set cases, and then we plan to have this washout period after the education, just to mitigate against this type of bias. So
perfect. And the control cases and the washout period after the educational session were also implemented to mitigate the same effect. And no significant increase was found from the first to the second round in the number of diagnoses of glandular abnormalities by individual reviewer for the control cases or the study cases not upgraded during the consensus conference. And the study was conducted at a large academic center with the educational resources, case volume, and expertise that might not be available at other institutions. In conclusion, of the pap test from patients with biopsy-proven endocervical adenocarcinoma, AIS, 72.2% were abnormal on cytology. Of the 22 false negative pap tests, sampling variants and interpretive variants each accounted for nearly one half of the false negative diagnosis. For the sampling variants, high-risk HPV co-testing can be essential for appropriate risk stratification and management. For interpretive variants attribution, under classification of abnormal endocervical cells as reactive endocervical cells or endometrial cells occurred, likely because the cells in these cases did not exhibit unequivocal features of glandular neoplasia. Educational instruction significantly decreased rate of interpretive variants and interobserver variability in the diagnosis of glandular abnormalities. Many cases still not accurately classified in the post-educational round. This describes the challenging nature in the evaluation of these cases. To further reduce the false negative interpretation, the high-risk HPV positive with negative PAP interpretation, especially with the hyperchromatic crowded groups or obscuring factors, might benefit from focused risk screening or intradepartmental consultation to improve the detection of subtle glandular neoplasia. This brings to us to the end of our presentation. Thank you, Dr. Okoye and Dr. Lim, for accepting our invitation and being here. And thank you, Dr. Rizal, for being here.
Thank you. Thank you, everybody. This was a great presentation, and thank you to Sukriti and also our graceful authors who agreed to join us, because it makes it a whole lot.
Thank you so much for the invitation. Really
Sure.
appreciate it.
No, it's really great because it really brings a different perspective. We read the articles, we go through the whole, exercise of it, but it's much better to see the people who actually worked on the project.
Right. And I think it motivates other people to even work on, research paper. I think it gives them idea how to do a project as well.
Sure. No, absolutely.
I am kind of monitoring the questions. So far, we had a very nice, saying about the presentation, but nothing as a question. But I'm going to just ask a question that I may have misunderstood. So the way that you have selected the cases was based on the biopsy-proven AIS or adenocarcinoma. And then you went back to see what were the PAPs on these cases. And that's where you found those 22 that were falsely negative. But the PAP tests that were somewhat abnormal, whether it was called, a squamous lesion of any sort, low grade, high grade, those were not part of your whole, I guess, study, correct?
Right, so those were part of the overall study, but those were not, we didn't consider those false negatives. So anything that had an atypical diagnosis, those were not considered in our, as part of our 22 cases.
Right, because
but we did compare.
Right, go ahead.
We did compare the clinical pathologic features with regards to patients that did have an atypical diagnosis on Pap test versus those that had the negative. So
very good. And within those cases that had an abnormal Pap, be it low grade, high grade, within those cases, how many of them on the biopsy were only AIS or glandular? Do you know, or did you look at that? Just to say that, are we still, again, I know that whole idea of being screening, if this is a screening test, Pap test is a screening test, is to bring the patient to some sort of follow-up and make sure that patient doesn't fall through the crack. So even if it was called high-grade squamous intraepithelial lesion, the patient would have seen, get a colposcopy, biopsy, and ECC. So hopefully by then the diagnosis would be clinched with AIS or adenocarcinoma, if that's the true diagnosis. So did you look at that? Was that part of whatever you compared or contrast?
With regards, yeah, so we did look at whether how many of them were in situ and invasive, and I think that's in that chart. I'm actually trying, I want to quote the right number, but it's in that that first figure.
Yes, I have the chart in front of me. So for the cases that had an abnormal Pap test, 84.6% were in situ and 15.4% were invasive, and the percentages were actually similar for those that had a negative Pap test as well.
Very good. Thank you. Thank you very much for your answer. The other question that I wanted to ask is that when, after all is said and done, were you able to figure out something that these cases, especially the false negative ones, had in common? I know that you looked at the screening variants, the interpretive variants, and all of that, but like, for the example, by the virtue of history, which we have, unfortunately, we don't get all the time, but were you able to see something that would trigger the screener to kind of say, okay, I need to be on more, scrutinize the Pap more?
Yeah, no, that's a great question. I mean, in terms of the clinical characteristics of the patients, we didn't really see any differences. Unfortunately, I mean, it would have been great if that were the case, but we didn't really see any major differences. I mean, thankfully, they all had a high-risk HPV 1618 positive Pap test, which is a bright red big flag, particularly the 1618. But there weren't any specific clinical characteristics. In terms of the, unfortunately too, in terms of the Pap test, there weren't that many diagnostic groups. I think that's really why, they were missed. But, paying attention to those that did have the hyperchromatic product groups, I think when we see that, we should pay more attention and, have a low threshold to show cases around when you do see those, which we do a lot at our institution, just, do curbside consults, show them around and get others' opinion. One thing I do want to kind of highlight is, I mean, this study is really focusing on the false negatives, but I do want to champion just the power of the Pap test because, over 70% of them were picked up by the Pap test, and the rest that were not, they all were high-risk HPV 1618 positive. So really there was no harm done per se. We were picking up these cases. And even if you look at the groups that did have a typical Pap test, that group that also had high-risk HPV testing done, there was a portion of high-risk HPV tests that were negative. So there were false negative high-risk HPV tests too. So no test is 100% perfect, but thankfully in those situations, what the high-risk HPV missed, the Pap test picked up. So I just wanted to that's an important point to make, that, there was no harm done, and, these cases were caught one way or another versus whether it's through the Pap test or through high-risk HPV screening. So.
Very good. Actually, that's the power of the combined, when you put your both hands in the pot. So you can get a much better result. And I think that's really, I think majority of people that I have come to talk to or in the organizations, they all feel the same. So I don't know how to go about the guidelines, but I guess we'll see how it goes. But as you mentioned, and as I mentioned anecdotally from my experience, which is a short-lived experience here, but we're not completely gone to primary screening. So I think we at least, hopefully we get to learn more about the benefits, or if there are advantages and disadvantages of everything, we'll learn more about it, and that would be great. One last thing that I wanted to ask also, sorry, I keep asking questions. I don't see any questions coming in. That's why I said, okay, let me ask my questions. Is that there was, as far as the sampling error, basically, is there anything that should be kind of conveyed to the operators, which are the people, you know, GYNs, primary practice, midwives, all the people who have a hand in acquiring the Pap test? Is there anything that can be kind of shown or kind of brought up to say that maybe everybody kind of has to have a better handling of getting a Pap test to actually get the cells that are abnormal? Or you think, I mean, I know that the numbers are not necessarily huge numbers, but it was like 10 of the screening, you know, variances, and then 10 of the sampling issues.
Yeah, that's a good question. I think you know, there's just inherent you know, glandular lesions are inherently prone to having this issue just because, you know, the location, it's hard to sample that high up. I think that's a really good point. I don't have any specific answer right now, but I think that's something to consider for sure.
Very good, very good. I'm looking one more time in my question box and I'm not seeing anything. Let me look at the chat box, and I don't see anything there either. I guess your presentation was so good. Nobody has questions about it. And we do have a good number of audiences that are joining us. And I would like at this point to thank them for their joining us, and thank you guys for making it a very worthy presentation. It was very nicely done.
Thank you so much, Dr. Rezai. Thank you again, Dr. Okoye and Dr. Lin, for your time and effort to be here. And thank you so much. Thank you.
Thank you very much for having us.
Thank you so much for the invitation. Really.
Thank you, Anna. Very good. Thank you very much for accepting it. I know everybody is busy, and taking time out of your busy days is really tough. We all are in there, but we really appreciate your effort to be there and shine light on your study, which was greatly done. I would just tell the audience, if they have any more questions about this or something that comes up to their mind, they can you know, reach out to the eJournal committee, and I would be Joanne Jenkins, which is our staff, and I would be very happy to kind of channel those questions to the right people, and hopefully everybody gets a very good you know, presentation of what they want to ask and what they want to hear. Very good.
Have a great
wonderful
rest.
Have a wonderful day. Bye.
Right.
Bye,
Thank you.
everybody. Thank you.